cochlear implant is a surgically implanted device that will electrically stimulate the nerve directly as opposed to an acoustic sound stimulation. As we know, cochlear implants do not make any sound. They're silent. They just stimulate the nerve by generating an electrical signal, and that's what the nerve interprets. And it's used for patients who've previously used hearing aids, and the hearing aids are becoming a minimal, if any, benefit. Did that look like it advanced okay?
Yeah. Yes, we're on slide 4 now, acoustic sound perception.
Great. Okay. So we'll continue this way. So with sound, simply enters the ear canal, and as a vibration, the sound will vibrate the eardrum and then pass along to the first bone, the second bone, third bone, the malleus, the incus, and the stapes, and then it vibrates the fluid inside the cochlea. Cochlea has basically 3 fluid channels in it, and then once the sound is received by the cochlea, small little sound receptors called outer hair cells basically convert the vibration sound and convert it to an electrical signal, and then that signal electrically travels down the nerve. And this acoustic signal can be enhanced or amplified by hearing aids. And of course, they have many different styles and formats that can be used and programmed with different technology levels. And this is what we're most familiar with, basically amplifying acoustic sound. However, if the ear can no longer process the acoustic sound, the cochlear implant will electrically stimulate the nerve directly. And so it basically will bypass the damaged portions of the cochlea, namely the outer hair cells, and stimulate the hearing nerve directly. And so several parts. We'll first have a external processor on the outside of the head, which magnetically adheres to the magnet of the processor under the skin, and then that sends the signal wirelessly through the skin to the electrode array, which is inside the cochlea, and that will stimulate the nerve directly. And this is just in terms of size. There's parts of a cochlear implant, the external processor, that we're more familiar with because we get to see that, but the internal part is what the magnet stimulates and then sends that signal down into an electrode into the cochlea. This, of course, is quite delicate, but inside the cochlea, if you have magnified the turns of the cochlea and did a cross-section, we would see that there's actually 3 fluid channels. And inside the cochlea, which is arranged 2.5 turns around, sort of like a snail, the cochlear implant sits in the bottom channel called the scala tympani, and the electrodes, as we see in the lower right, they're little banded electrodes on a pre-curved electrode array, and it fits into the turn of the cochlea. And once the implant is healed, electricity is sent down the small wires in the electrode array to the banded electrodes, and that will then send electrical stimulus to the nerve fibers going to the 8th cranial nerve going to the brain, and then you are able to hear with that. So who is a candidate for adults versus kids? It's different, but for adults, sentence understanding scores are used to determine candidacy, not so much like a conventional hearing aid where you're listening to beeps and tones. It's mainly sentence understanding. The FDA as well as Medicare have their own criteria. FDA criteria are a little easier to qualify for a cochlear implant. Medicare criteria is a little more difficult to qualify for a cochlear implant, but Medicare does cover cochlear implants, which is quite a benefit. From the FDA criteria, it requires a speech understanding score of 50% or worse for the ear that's to be implanted, and no better than 60% correct for the non-implanted ear or the other ear. So one could wear a cochlear implant on one side, a hearing aid on the other, and become what's called a bimodal user, and that's actually quite common. Medicare also has their own criteria. That bar is a little bit higher and require inclusion criteria of no better than 40% of the words correct. So you need to have more hearing loss to qualify under Medicare criteria. So benefits in general, most patients, not all, but most will develop the ability to recognize speech without looking at the speaker, or improve on their ability to understand speech with minimal visual feedback. They commonly can use telephone, not always, and most users will be able to use the implant and improve in task recognizing environmental sounds, speech and lip reading, and hearing soft sounds, and monitoring voice inflections and sounds that they have not heard in the past or in a very long time. Factors affecting the benefit. The duration of hearing loss plays a rather significant role. Ideal candidates for cochlear implants have been deaf in an ear for less than 10 years. If profound hearing loss is longer than 10 years, there's some documented nerve degeneration that can happen in the cranial nerve, in which it will have less ability for the cochlear implant to stimulate that nerve effectively. So ideally, sooner the better. As soon as a person becomes a candidate, the better the result will be. Having speech already developed, especially for adults, makes for a better candidate. An adult who has been deaf for many years and has not developed speech or communicates with ASL would usually not be expected to acquire speech awareness in the implanted ear. They may develop environmental sound awareness, which can be very helpful, but in a patient who is an adult and has been deaf without speech development may be a poorer candidate to benefit from a cochlear implant. Quite different from a pediatric population where prelingually deafened pediatric patient is eminently able to benefit from a cochlear implant as long as they are implanted again sooner than later. The status of the cochlea makes a difference, especially in the more of the pediatric population. Sometimes the cochlea will be malformed and will not allow adequate placement of an implant. Sometimes some medical conditions will preclude a person from being under a general anesthetic, which is currently required for placement, and either heart or lung conditions may preclude implantation. And then also patient motivation. The ideal patient would be a very motivated adult to make the implant work, or very motivated parents in a pediatric patient. In young pediatric patients, causal factors for hearing loss can be quite numerous, ranging anywhere from metabolic problems to viral problems to developmental abnormalities in anatomy. But it is very common. Hearing loss can be present in 1 out of every 750 infants born. These are better, patients are better identified early nowadays with, at least in the state of Indiana, with nearly universal auditory screening prior to discharge from a hospital to go home. And no infant is too young to undergo hearing testing. It just depends on what type of testing the patient may need. And delay in detection leads to loss of development of essential skills in speech and language and social interaction. So ideally, we'd like to identify the pediatric patients as soon as possible. Pediatric cochlear implant candidates have have different criteria than adults. We usually are looking at age 12 months or older, though some indications can take patients down to 6 months for implantation. Typically, they have a severe to profound hearing loss in both ears and no appreciable benefit from hearing aids, no medical contraindications, and ideally be enrolled or to be enrolled in a education program that emphasizes development of auditory skills, which would be like an auditory verbal preschool. And ideally, highly motivated parents who have appropriate expectations with the implant are best candidates. Expanded criteria for kids, for infants 1 to 2 years old, require both ears to have a profound hearing loss and pretty much have plateaued in the development of auditory skills. And this is assessed best by the audiologist as well as a speech and language pathologist. In older kids, 2 years to 17 years, may have a severe through profound hearing loss in both ears. Again, plateau in development and auditory skills. And there will be word tests that can be given, and they'll typically score below 30% in their best aided condition. So how do implants look? And that has changed over time. Implants, the internal portion of implants have decreased in size rather dramatically, even in the time that I've practiced in the last 20 years. Initially, the implanted portion of the cochlear implant was not a very slim silicone wafer that is present nowadays, but it used to be a ceramic fragile box that would be placed with a very large incision, almost a craniotomy incision in the back of the head. It honestly looked like somebody was trying to hide a package of cigarettes under the skin. It is quite a change in technology over the years in the miniaturization of the processor as well as the internals. But depending on one's haircut, one can either see the device or it can be actually quite easily covered by longer hair, and obviously can be a behind-the-ear device, which is most common, but manufacturers now also make standalone magnetic devices that just sit right on the internal without a behind-the-ear component. But there are some pros and cons of each of these that usually the audiologist would preoperatively go over with a prospective patient to pick and choose what they feel would work the best in their typical listening environment. Prior to surgery, several outpatient tests are usually needed. These might include some scanning, whether it be a CAT scan to look at the bone anatomy of the middle ear and inner ear to make sure that the cochlear implant can get into the cochlea. An MRI, which would look more at soft tissue to make sure that there's no other causes for hearing loss that would potentially interfere with how an implant works, such as a tumor or abnormal fluid collection or some type of inflammation that we would ideally like to know before an implant was placed. Hearing testing is quite obvious, and this is typically testing that is quite extensive with a best aided condition called a cochlear implant evaluation, in which a patient is listening to sentences, pages of sentences, in which we're just literally calculating the words the patient gets correct versus the incorrect words. We'll tally that up and arrive at a percentage, and that will give us the raw data that we would need to determine if a patient would be a candidate in meeting either FDA or Medicare criteria. Testing can take anywhere from about 1 hour to an hour and a half. Sometimes balance might be needed to be assessed, especially if the cause of hearing loss had to do with an inner ear problem related to balance conditions such as Meniere's disease or labyrinthitis. And then lastly, consulting with insurance less of an issue with Medicare because it's a covered benefit, and there is no, in any Medicare surgery, there is no pre-certification like a private pay insurance company. But private pay insurance companies, we always will need to check, obviously, prior to surgery, what the benefit a patient's insurance would offer. General concerns, which are fairly universal. How long is the surgery? Usually about an hour, in which it takes to place the implant. Is it painful? And typically people may take a minimal amount of pain medicine after surgery, anywhere from 1 to 3 days after surgery. Most can get by with some ibuprofen, but if needed to be a stronger pain medicine, we supply that. Risks and side effects. The main thing that people have significant pause about with a cochlear implant is that, and it does depend on how much residual hearing an ear has, but for most patients, I will advise that we will anticipate losing the rest of the native hearing in that ear. So that the ear will work with the cochlear implant, but only when the processor is on. And so if a patient is determined to be a cochlear implant candidate, studies have shown even if a patient's ear has residual hearing, if they are a candidate, they will do better with the implant than they will with the hearing aid, even with the minimal residual hearing. And so that sometimes can be more reassuring to a patient to know that if they meet the criteria, then they can proceed. With some assurance that they will do better post-operatively than they will have done preoperatively. The trick is that it takes a while to get good at using a cochlear implant. And so I usually tell folks it takes about a good minimum 6 months to get facile with a cochlear implant. A hearing aid works differently, in which you turn a hearing aid on, and the best day ever will be the first day it is turned on. Cochlear implants, I will usually advise patients, the worst that the cochlear implant will ever work will be the first day it is turned on. So over time, for most patients, improvement in hearing performance takes place over the ensuing months, unlike a hearing aid. Usually we switch it on at about 1 month after surgery. It basically, by that time, swelling has gone down, pain is better, and they're better able to tolerate placement of the external processor. How often does it not work? It is rare, but the answer is about 1 to 2% of the time cochlear implant will not work. If it is what's called a hard failure, which is an electronic failure inside the cochlear implant, we will usually recommend removing it and putting a new one in with surgery, and then the ear is back up to speed. Any limitations on activities? The thing we usually recommend is trying to avoid static electricity. Mainly in kids, we usually recommend avoiding plastic slides in which they'll generate a lot of plastic electrical activity from static electric discharge, which can sometimes deprogram the external processor. And they're designed to last for life. The internal is designed to last forever. The external device usually will be eligible for updating every 5 years, and that also is covered with Medicare. So with the surgery, it's a same-day surgery, go home the same day. And like I said, the anesthesia is anywhere from an hour to an hour and a half. Usually wear a bandage for about 2 days. And implant is commonly checked during surgery, sometimes acoustically with electronic testing, sometimes radiographically with checking an X-ray. And usually the implant is turned on for programming at about 3 to 4 weeks after surgery. And all ages are potential candidates. After surgery, programming by the audiologist is very, very important. The patients always need to realize that the surgery is actually only the first step and in the grand scheme of things can be a fairly simple step. The audiology programming is the difficult part and is time consuming, and typically starts usually weekly for a month after surgery, and then will decrease in frequency, and then ultimately most patients will require a programming check perhaps 1 to 2, sometimes 3 times a year, but most about 1 to 2 times a year. And the longer a patient is a user, usually the less frequently they will need to get adjusted. Hearing aid may still be used in the opposite ear. Like I said in the past, it's a bimodal user, and that's actually quite common. Probably more than 50 to 60% of patients are bimodal users. Usually I recommend with both, with Medicare, both ears have to be qualifying to be a candidate to even implant one ear. I will usually recommend implanting the worst hearing ear unless there is some predisposing factor that would preclude the worst hearing ear from being implanted. 2 implants can be implanted if needed. And especially for children, it's a significant importance on auditory verbal rehabilitation. This is less of an issue for an adult. Adults can commonly do some, in the grand scheme of things, relatively minimal auditory verbal rehabilitation, even on the Cochlear Implant Company's websites, in which they have portals to practice speech and language and listening skills. However, in children, prelingually deafened children, this takes it to a whole different level, and a auditory verbal preschool would be fairly mandatory with a 1 to 2, 3, 4-year-old child with a cochlear implant in order to maximize the use of the cochlear implant. In the Indianapolis area, St. Joseph Institute of the Deaf has been working for more than 25 years, originally based out of St. Louis, and is internationally known actually for their excellence. So we're quite fortunate in Indianapolis to have a rather a bit of a superstar in terms of auditory verbal rehabilitation in the pediatric population. And they'll have at any one time 25 to 30 kids that are usually pre-kindergarten in school and learning very intensive speech and language skills, and most are mainstreamed into a program in a standard school situation by kindergarten, and with actually minimal need for external help, just managing on their own, which I think is just truly amazing. Future of cochlear implantation, and we'll talk about some neat things that have rather recently come about or have just come about. So hybrid technology has been around for a few years, and what that is a device in which is sort of half cochlear implant, half hearing aid, and that is a hybrid cochlear implant. These are not very common. You would think that they would be, but they're not. Part of the issue is that Medicare does not actually have coverage for hybrid implants at this time, though they've been reviewing that for a number of years. So there will be very few of these devices out there in the public. It is trying to broaden the fitting range of patients who have residual low frequency hearing. Basically, turns out if you have a ear that has a significant amount of low frequency residual hearing, but the patient is very, very compromised in how well they're doing with their hearing aid, if you have a special short electrode that stimulates the high frequency part of the cochlea, and again, this is a short electrode, it's specific for a hybrid implant, that you can put it in, have in a very, very careful fashion to try to preserve that low frequency hearing. It turns out once they're healed and they have a recheck of their hearing, assuming we are able to preserve the low frequency hearing, the person can use a device that is applying electrical energy to the inner ear for the high frequencies, and they're using acoustic stimulus to stimulate the low frequencies. So it's a single ear, kind of a bimodal device. That is a hybrid device. Typically, that is by the Cochlear Americas company. This shows some of the more detailed fitting criteria, which is different than a conventional hearing requirement for a cochlear implant. Just looking at this is a fitting diagram for a cochlear implant. On the upper left would be a standard cochlear implant. The type of hearing loss on an audiogram that an audiologist would look at, that person would be in a fitting range of a cochlear implant versus the hybrid implant on the bottom right. We can see that the fitting range is quite extensive in terms of who may qualify for a hybrid. The difficulty in my experience with the patients I have done cochlear implants that are hybrids is that typically a person has been using hearing aids, and hearing can sometimes decrease slowly over time. And when they get to the point where they've maxed out the hearing aid benefit, a person starts to think about a cochlear implant. With a hybrid implant, we're trying to preserve that low frequency hearing. The difficulty is once the implant, the hybrid implant is placed, that underlying hearing loss that can be progressive can still be going on in the background. And over a number of years, a person may then continue to lose that low frequency hearing that they were using the acoustic part of their hybrid implant, and then it becomes no longer usable. And so this is one of the drawbacks which can be a significant drawback of a hybrid implant, is that over time, if there's additional kind of natural hearing loss that progresses in the low frequencies, then they have a short implant that they're really only getting some of the high frequencies electrically stimulated, and portion of the cochlea is not able to be stimulated by the cochlear implant that is in place. And so I actually have had to remove some hybrid implants over time to replace them with long electrodes so that the rest of the cochlea can be stimulated. However, this implant technology is out there and just something to be aware of, and very interesting technology. And it is quite effective in terms of improving speech and understanding and quiet and noise. On the percent correct of the words is the axis on the left, and basically two bar graphs, and these are just showing the black would be a preoperative value for how good a person was doing, and then the blue bar is postoperatively, and pretty significant improvement in the hearing with the hybrid device. And then satisfaction also is quite good with this device as well. And again, I bring it up because this is fairly new. So preoperatively is on the left, the postoperatively is on the right, and satisfied patients are in the yellow. So starting out not very satisfied, and then after surgery fairly satisfied. More recently, there's been a push to try to identify earlier more of the potential patients that could benefit from a cochlear implant. Only 10% of potential candidates for cochlear implants actually have a cochlear implant. That means we, as a profession, whether it be medical doctors or audiologists, are missing 90% of the potential patients out there. That's a lot of people, and the word needs to get out. And so what the push is, and just recently within the last year, is to for an audiologist to start to think about considering recommending a cochlear implant evaluation for a patient who had otherwise previously been not able to be identified audiometrically, but it's on an audiogram a speech discrimination score of 60% and a speech reception threshold of 60 decibels. And this is kind of a new push from the audiologist standpoint to kind of mentally get themselves into a mindset that if they see a patient that are presenting with these types of numbers on a conventional audiogram, that they should start thinking about recommending the patient for evaluation. So this is not so much for general public, but more from the audiologic standpoint, and how it is quite difficult over time for the inertia of what traditionally audiologists have thought would be a cochlear implant versus now what's being advocated as having basically a lower bar that patients may be able to qualify for a cochlear implant. So this can potentially identify more people and help more people earlier on, so they do not have to struggle as long with the hearing aids before they're able to be identified as a cochlear implant candidate. So this is a big push by the audiologic side of medicine. Single-sided deafness is another rather new indication with cochlear implants in Europe. Europe always seems to be ahead of the United States when it comes to hearing loss, but in Europe, single-sided deafness has been an indication for a cochlear implant for probably close to 15 years. Unfortunately, the U.S. was a little slow, but the FDA fortunately did approve it in 2019 for patients with one-sided deafness greater than 5 years old, age greater than 5 years old. So this is a bit of a significant change in what we can recommend professionally for people with hearing loss. They will, with cochlear implant, have improved speech perception and noise, and improved spatial awareness, because with single-sided deafness, a patient with one ear that does not work, that patient cannot tell where sound is coming from. And if you have something like a cross hearing aid or a bicross hearing aid, that still can't help bring back direction, because that hearing aid is still routing signal from the bad ear to the better ear. But a cochlear implant is the only technology that we have to bring back hearing in a one-sided deafness situation. They have better listening and less fatigue and less effort for listening in general conversations, and better participation in socially and in work. So I just wanted to discuss a bit about some of these newer things with cochlear implants, as well as some general things, but and then also obviously to see if folks had questions that they were thinking about. There we go. Stop presenting.
Okay. We do have questions.
Yes.
And Kathy has raised her hand, so we can go to Kathy first.
Okay. I just want to know why your office only allows certain insurances. Why don't you cover a whole variety of insurances? That's the reason why I don't go to you. I would love to go to you, but I can't.
We participate in almost 60 different insurances. There are quite a number of insurances out there, and in the end, we end up having to go with the ones that we're able to participate in, that have the most patients that would be part of an insurance group. Unfortunately, I have a limited bandwidth in terms of how many patients I can see, and in the end, that probably is the biggest reason, is that I can't participate with all the insurances. I just don't have the ability to see that many people, even with my nurse practitioner.
Okay.
Thank you. I posed 2 questions in the chat box. Can you see the chat box? It's the
Okay. Yes. Okay. Okay.
where it says Q, and it's me. The first one is, I'm an individual with Meniere's disease. I was tested 2 different times as a possible candidate for CI. The first time I was a candidate and the second time I was not due to fluctuations in hearing. What is the gain for the 40% speech understanding patient in this scenario, especially since hearing changes quite frequently? That's the first question.
I'm looking at in-call messages.
Look on 1044.
Gotcha. Okay, I got to scroll up. Okay, got it. Okay. So with Meniere's is a unique ear condition in which we do get fluctuating inner ear hearing loss. And so commonly over time, hearing tends to decrease over time, and not always. And it is variable right side versus left side. And so I have seen where a person might be a candidate on a bad day and then not a candidate on a good day. Ideally, if the hearing is able to be reversed, whether it be with oral steroids or with transcampanic steroid therapy, and the hearing is improved back into an aidable range, I definitely would recommend staying with the hearing aids. However, if the hearing remained down, there was no recovery with low salt diet, the diuretic, and steroid therapy, and the person was a candidate, continuing to be a candidate for a cochlear implant, then the gain that one would expect typically if a person was at or just below that 40% understanding score, typically a person might even be up into the 80% to 90% at about 6 to 12 months after surgery would be common. Now, could a person with Meniere's still get variations in the performance with a cochlear implant after surgery? The answer is yes. So you can still get variable function with the cochlear implant. Still, because the fluid pressure is changing in the inner ear. Just because the implant is placed, unfortunately, still the Meniere's is going on in the background. The Meniere's is still not cured. There is still not a known cure for Meniere's.
Thank you so much. I wondered about that, so I appreciate your answer. The next question is, will the hybrid implant help high frequency hearing loss? I heard you say low frequency, but didn't hear if you said high frequency.
Yeah, so the hybrid is designed to help high frequency hearing loss. It is trying to preserve the native low frequency undisturbed. The low frequency ideally is what is trying to be stimulated acoustically. So the low frequency is acoustic, the high frequency is electric. Like I said, the difficulty with the hybrid implant is that whatever the person's underlying hearing loss cause was, sometimes that hearing loss still continues even after that short electrode is placed. And that potentially can be a problem because initially there might be residual low frequency hearing that the hearing aid portion is helping, but over time that hearing may wane, and then the hearing aid part doesn't work anymore. And so in that is, in my view, probably the biggest reason why hybrid implants are not very common is that, in my experience, it's not a really great lasting result. It tends to wane over a couple of years.
I see. Okay. Thank you so much for answering.
I think where the hybrid implant will go, which will come down to the manufacturing research and development will be developing a long electrode that is very thin that does not cause hearing loss when you place it. And then a person may start out with using part of the array for high frequency, and if and when the low frequency hearing loss starts to go away and they can no longer use the hearing aid part of the processor, then the end of the cochlear implant then can be turned on at a later date. So that's probably where hybrid technology will go. Will be the person will get a long electrode with the capability of stimulating the whole cochlea, and then it just gets slowly turned on over time if the low frequency is lost.
Wow, that's very interesting.
Yep.
Thank you. Any other questions for Dr. Ostrowski? Cindy?
Thank you. This is a question that is just pretty much strictly my curiosity. I was totally blown away when I found out that the cochlear implant would be covered by Medicare. One of the wonderful things about getting older. But I guess my question is, why is there such a different attitude towards hearing aids when you spend your entire life trying to work and to pay for a hearing aid, and you need to be a functioning individual, and you're getting absolutely no help at all financially, and then all of a sudden the cochlear implant, it's totally covered. I mean, why the two different attitudes? Can you explain it all?
I think, at least from the government point, with Medicare and with insurance, I think ultimately it comes down to money is the bottom line. I think from the way that insurance companies look at hearing loss, they're looking at what the risk pool is, and cochlear implant risk pool is relatively very small number of people compared to those who could benefit with hearing aids. And I think it's a cost-saving measure, so that they know, the government, at least with Medicare, knows that, yes, cochlear implants are very expensive, but they will probably save more money on fewer patients with cochlear implants than they would with a whole bunch of people needing hearing aids. I just think it's a money thing.
The numbers. Okay, yeah. Thank you.
Unfortunately, yep.
Yeah, that is unfortunate, but yeah, it does make sense. Anyone else? Yes, Ella reminds us that real ear verification when you're getting fitting for hearing aids, and 30% of practices do this, so it's good for people in our chapter to encourage more audiologists to do this. Previous speakers to the chapter have advocated for real ear verifications. Please comment. Would you like to comment on that, Doctor?
Yes. So a real ear measure is a means in which the audiologist can kind of real time figure out what the benefit for the hearing aid is for that patient. In our office, we do now have real ear measure, so happy to say that. It is not commonly done. Almost all the time, hearing aids are programmed based off of the audiogram, and that is almost always how hearing aids are done. But there can be some additional information that the audiologist can gather from a real ear measure to make some additional, hearing aid adjustments that can be helpful. So yes, it is a rarity that you will run across a real ear measure.
Okay, thank you. Any other questions or comments, please? Ella asked, may we occasionally use you as a source to answer general questions from our chapter members? Would
Sure.
you be interested in maybe a future professional membership? We do
Oh,
have
sure.
that.
Sure.
Oh,
Yep.
that'd be awesome. You'd be, kind of like our go-to person for, expertise. So this is awesome.
Yep. Happy to help.
Thank you. Any other questions before we wrap up with Dr. Paula, did you have a question? Okay, no, I see her name. Okay. Nothing like coloring, I guess. Bruce made a comment. Okay, it's a cute comment. Anyone? Oh, Ella has her hands raised.
Because we are such advocates for hearing loops, we are concerned that there seems to be a trend to miniaturize hearing aids by taking out the telecoil and having that as an optional extra. That is disconcerting. Is that the case? We're still not quite sure with the Cochlear America's new Kenzo 2 that there is no telecoil in the device itself, or did they come around it in another way to be able to still use telecoils, but it being in another device?
Ooh, that's a good question. That would actually be the best question for my audiologist. For the Kenzo 2, I am not sure about that in terms of what Cochlear has in terms of a coil in that device. For those who don't know what the Kenzo is, it is it's a processor that Cochlear America makes that sits completely over the magnet, and there's nothing on your ear. So it looks like about the size of a half a dollar. That's kind of circular. So that has the battery in it, all the processing, the coil. But from the telecoil standpoint, I would actually have to ask my audiologist.
Well, it's just disappointing that seems to be the trend that we're seeing, and that was why we were very instrumental in passing the law 2 years ago in Indiana, so that audiologists would inform their patients about telecoils, and so that they could make a better decision whether to have a hearing aid with a telecoil or one without. But we're still disappointed with the trend, and we're just hoping that this technology will continue to advance. If we don't have people with telecoils, then no one's going to be able to use the loops.
Bruce raised his hand. Go ahead, Bruce.
Yeah, I just think that the current marketing trend is that cell phones and Bluetooth connectivity are the way that all the manufacturers are going. And I think they view a telecoil as old technology, that, people were using telecoil with the acoustic landline phones, and they don't see the marketing need for the telecoil. And I think that we as consumers have to go back to the manufacturers and stress that, this is what we want. This is something that we need, and that this technology has been around for a long time in telecoil, but it's still viable and still usable and something that we want. And so I think it's up for us to drive back to the manufacturers to make that issue happen.
Thank you, Bruce. That is an excellent point, and I think Dr. Sturkins has talked about that in the past, and she's still advocating for that kind of advocacy throughout the hearing loop world, if you will. So thank you for that reminder that we need to voice our advocacy with the manufacturers, because that's where it really begins. Anyone else? No? Okay, well, that wraps up this presentation. We want to thank you so much for spending time with us and sharing this vital information. It certainly has been educational and enlightening, actually. And I want to say that our group is going to send you a certification appreciation for you having been here to this morning with us. So we really want to thank you so much again for your time and sharing of information.
Well, it's my pleasure, and thanks all for attending, and thanks for inviting me, Ella. Thank you.
Thank you so much. We will get that to you by email, okay?
No
So
problem.
expect that certification coming in the mail.
Great. Thank you.
Does anyone else have any comments or questions?
He's the only guy that's been inside my head.
There's one question Paula has asked, does Dr. Ostrowski, do you have a hearing loop in your office? It says.
We're at the moment, no. We're but in the process of trialing one. Yes.
It looks like Julie has put something in the chat box. Okay. Dr. Ostrowski, I will be undergoing a fourth procedure on August 17th on my aneurysm. After the second procedure a year ago, I have noticed that I have greater difficulty in understanding what is said in certain settings. I have become more reliant on captioning. Do you see this problem occurring with other people who have surgery, and can a cochlear implant help?
Well, with an aneurysm, assuming this is an intracranial aneurysm, one that's inside the brain, these are extraordinarily delicate procedures and operations. So depending on where the aneurysm is, that theoretically could affect the speech processing or sound processing areas, whether it be near the brainstem or the left temporal lobe of the brain, and that can interfere with how one perceives sound. So it's a difficult question. One would need to look at the audiogram. That would be a first step, and then depending on what the audiogram looks like, whether or not a patient would be a cochlear implant candidate, implant evaluation would determine that definitively.
dentalcare.com, basic. Clinicians must use comprehensive evaluation and assessment to determine if a patient is eligible for dental implants. If dental implants are placed, it is the role of each clinician to reevaluate and assess the implant patient to prevent potential implant
I don't know what happened there.
Sorry.
Find out more. Look for the link in your Google Home or Google Assistant app.
But I guess a contraindication with an aneurysm would be if the repair of the aneurysm in any way was directly related to the eighth cranial nerve, which is the cochlear nerve coming from the inner ear to the brainstem. An aneurysm would be a contraindication. A tumor would be another contraindication, in which the message from the cochlear implant would not be able to get to the brain in an organized fashion. So I know that's a really long answer to a fairly simple question, but it's actually a fairly complex question. Hopefully that helps.
I apologize for the intrusion, but I figured it out. I have an Alexa, and she must have picked up on a question somewhere while Dr. Ostrowski was speaking, and Alexa put in her 2 cents worth.
I can assure Alexa that I would not be able to talk about dental implants.
I'd love to know a little bit more about the regeneration of hearing, the cilia. I know there are a lot of advances going in that direction. So are we to hold off our cochlear implants, waiting for cell generation to come on board, or maybe just have one ear implanted and have the other one in reserve in case the cell generation comes within the next 10 years?
So I do get this question often, and the kind of two areas of benchtop research going on for hair cell regeneration trying to improve hearing are stem cell transplant and gene therapy. A stem cell transplant or gene therapy in animal models both have been shown to allow improved hearing. Say if you take a deaf chinchilla or a deaf gerbil model and do the transplant or the gene therapy, you can get them hearing again. And looking at the hair cells, they do get repopulation of hair cells. We've not done that yet in humans, and from feedback at our National Academy meetings, it probably will be going to the FDA for approval, but time frame looks to be somewhere around 20 years that the FDA would take to certify something like that for humans. Stem cell transplants, people are fairly familiar with. Gene therapy is a little bit different. Most people may not know what that is, and that's taking a virus, taking the genetic code of the virus out and putting a new genetic code, say, for a hair cell into the virus. As we all know, viruses are very good at infecting humans. And if you have a virus like a Trojan horse and you put a stem cell, a genetic code for a hair cell in the virus, that virus will take that and ideally repopulate the hair cells in the cochlea. Now, again, that's probably going to be about 20 years if all goes well. So answering the question, should I hold off on a cochlear implant waiting for stem cell or gene therapy, my answer right now would be no. But it would it does, I guess, depend a little bit on the age of the patient. However, if a person is bilaterally, severely or profoundly deaf, the difficulty is that even if the person were to wait, that eighth nerve is going to degenerate because it's not being stimulated. So even if you did do a stem cell transplant or a gene therapy and repopulated the hair cells, by that time and you were waiting, the hair cell may not be able to stimulate that eighth cranial nerve in order to send the message to the brain. And so I personally don't think that waiting is good, because you're going to still get nerve degeneration in the eighth nerve. And the hair cell transplant or gene therapy may not work. And then ultimately, if you were trying to fall back on a cochlear implant, ideally, like in my talk, we tried to get things implanted by 10 years. And if a person was waiting a long time, that even the implant may not work.
Mm-hmm. I do recall one other question that we have from members.
That's
Some
amazing. By then, I'll probably be dead.
And they do all the...
In 20 years, who knows?
I don't even know if he'll be in my lifetime here.
I was so cautious my Alexa wasn't talking that I turned off my microphone. I do have one question that has recurred a number of times from our members with cochlear implants. Once you get implanted, there are exercises that you do to increase your understanding of the words, and you continue to increase that gets to be better as time progresses. But does it plateau, and the bit that doesn't get comprehended, even in the most ideal situation, is that something to do with the processing of language somewhere in the brain rather than the actual exercises and the hearing of the sounds?
It probably is a little bit of both. There's also limitations to the cochlear implant. I mean, granted, these are pretty wonderful devices, but by no means are they perfect. And it is very hard to hear music. The complexity of music is very different than the complexity or simplicity of speech. And so, these are devices that are, 16 channels or 24 channels, and those are the number of electrodes. And despite having so few electrodes, there is a limit in terms of how much information could be sent down that little wire to the cochlea. And so the rehabilitation is very helpful, but yes, there's definitely going to be a plateau. Usually adults start to see that plateau at around 6 months, but we'll see improvement continuing even out to 12 months and 18 months with that. And then sometimes with new upgraded processors, there can be another little jump after the new processor. So the technology is fairly fluid. People commonly ask, well, do I need to have the internal part changed out to match the new technology coming down the road? The answer is no. Manufacturers are currently only using about 30 to 40% of the bandwidth of that internal device. So they're anticipating new, fancier technology, new processing coming down the road that will then be able to be used by the internal device. So all the changes are going to probably happen with the processing on the outside rather than the electrode on the inside. But there occasionally are implant improvements on the internal part. But yes, there is a plateau in terms of performance.
The other comment is we've heard of laser being used, which will, for the little, the nodes, so you can fit more discrete changes in sound frequency. Mm-hmm. How far along the path is the use of laser for nodes to keep the beam parallel rather than spreading and therefore getting clearer sounds at different frequencies?
Using light laser, using coherent light to stimulate hair cells, that is not, to my knowledge, not in any clinical trials right now, but that is a technology that could be used. But that would be fairly involved in terms of putting that small of a laser delivery device inside the cochlea. But the exactness of the laser would be very very impressive. But getting it small enough to get that type of bandwidth into the cochlea, I think, is the limiting factor. But I don't know of any human trials that's going on right now with laser.
Thank you.
Okay. Well, we've actually overextended your time, Doctor, but we really appreciate everything. And like I said, expect an email with our appreciation. So.
Well, happy to talk today, and hopefully learn some information, and thank you very much.
Thank you.
Thank you.
Yep. And have a good weekend.
You too. If any member wants to stay